Okay, dear Nat, we are recording this video. You will receive this video and also this PowerPoint presentation, and last but not least, the manuscript, the whole manuscript. So Dina and I believe that the best way to express ourselves about this project is by recording this video. So Dina is online as well. So I will start by saying that the idea of this diabetic retinopathy tele-IMD or telemedicine is to detect the early stages in diabetic retinopathy, that they are progressing in developing countries mostly, and nowadays causes 46 million of people blind due to a preventable condition, that is diabetic retinopathy. So the idea is to set different angiographers around the world. Those pictures will be taken by the nurses or the general practitioners, and those pictures will be sent to the reading center, which involves, of course, the Tel Aviv Sourasky Medical Center and the University of Buenos Aires. And with those, we will, Dina and I and the physician you decide on that, we will read those and refer those pictures right away in 1 or 2 minutes, saying which patient need a further investigation and be referred to a local ophthalmologist just to get laser and treat those in early stages. So nowadays we focus only on DME, but if the condition progresses, and if this time we can see that if this patient had laser performed at this time, this will not have been the condition at the next picture. So this patient progresses and then they develop traction, and of course the laser was very badly done. The condition progresses and then we have that, which is blind due to a tractional diabetic detachment. And we still see in a lot of patients, even young patients, the first appointment they have a tractional diabetic retinopathy with a lot of retinal detachment and traction, and the vitrectomy is the first thing that we should do. Again, if this patient on this video and the surgery had laser in 10 years before this wouldn't have been the scenario.
Hi, Anna. So we would like to point out that there's a huge amount of patients around the world that suffer from blindness due to a preventable disease. And if those patients would have had an easily screening test when they were diagnosed with diabetes, those conditions, of course, could have been prevented by easy PRP treatment.
Yeah, and the main point of the trade point of this project and research project that we are that you are going to present in Amsterdam is there's a high disease prevalence and low DR screening coverage around the world, of course mostly in developing countries. The potential cost saving, for instance, in South America, in more than 100 million US dollars. So with this project, we are not only to save patient sites, but also save a lot of money, not only for the health insurance system, but also for governments. So this is a very, everything adds up if you are thinking from the patient point of view or from the medical system point of view. It's a win-win situation.
And this slide is only to sum up the problem again, but I think it should be pointed out that the guidelines are very clear. In most of the countries, everybody indicates that people, when they are diagnosed with diabetes, should be screened, but this does not happen because of poor coverage, mainly in the developing world.
And again, as we have been saying over and over again, and you can see on the screen, and this was published by the International Diabetic Federation, the diabetic condition is not getting any better. By 2050, the cases of diabetic patients, and of course the consequences of diabetic in the eye, will be duplicated. So if we don't do something now, the consequences will be even worse. And by 2050, instead of having a lot of patients, we will get a huge amount of patients and this should be fixed or should be at least treated with this project, which is early stage, early treatment, ended up in better results.
And just to make the problem even bigger, there are about 46% of patients worldwide that they're still undiagnosed with diabetes. And of course, the spendings on treating diabetes complications are very high, but which is maybe different from other specialities in ophthalmology. Those costs could have been cut down with early treatment.
Yeah, that's a very important point. We're trying to let them know that if we treat those patients early, the disease will almost disappear with very well metabolic control at the same time. But this is not more expensive. It will save a lot of money. That's an important point maybe you can raise in Amsterdam. So going to the key drivers, Dinale.
Yes. So of course there's the current standard of care, which is an ophthalmology exam with dilated pupils. But this does not happen because of the poor coverage in certain areas. And on the other hand, we have those modern imaging analysis systems that are very feasible, and they are not expensive today anymore. And telemedicine is rising, especially in ophthalmology, and in telemedicine we need a small investment which can save huge reimbursement. But of course, the main point is not only the money, but the patients in the center here.
Mm-hmm. And this is a very nice paper that Dina put it on the presentation, and this was published on JAMA Ophthalmology in 2007, and the editor was asking himself why, if the diabetic retinopathy is treated, it could be treated easily, why they are still seeing young patients with loss of vision due to this condition. And the answer was that the need for diabetic retinopathy screening with telemedicine was mandatory, and this was 2007. So 12 years later, 2017, sorry.
2 years later.
Yes, 3 years has passed, maybe 2 years if you say May. 2 years has passed and no one has put in practice tele-IMD, so telemedicine. So we need to do it, and this is why we really believe that our research program is one of the tools that we will have very fast and very easily in order to avoid this condition and incident of blindness due to diabetic retinopathy.
So of course we're not the first to look at this. The feasibility and the efficacy of automatic detection has been shown before using deep learning, and it has also been shown that those programs will be very cost effective in national pilot projects. But on the other hand, those projects are not running outside of a research setting. And even more, it has been shown that those automatic detection algorithms can be used in a publicly available data set in order to integrate deep learning. And this is what we want to do. We don't want to invent the wheel from the beginning, but use the existing algorithms and improve those on large data sets that we are going to obtain while doing the manual step of the project, which we will show you now.
Yeah, so if you go back, Dina, only one slide. So on the bottom you can see improve. So of course we are trying, the algorithm already exists in order to detect, but no one is using it widely. So we are trying to improve that algorithm by doing that. So if someone raised that question, we are saying that we know that the algorithm already exists, but we are going to improve it because it's not on duty, or no one is using it right nowadays because there are a lot of pitfalls. So our project, going back to the project, is divided into steps. Of course, the first steps is the eye screening. So pictures will be taken by the general practitioners or the nurses in very, very lost areas in around the world, we are going to start in Argentina because we already started here and the facilities are already there. And then simple screening method ensure a global coverage, which is a simple picture. That picture will be sent to the ready center or the data transfer, which is the step number 2. And the number 2 will be Dina and I or every physician you decide. We are going to read those pictures and we are going to send right away, step number 3, the result of recommended treatment. If the patient doesn't have any sign of diabetic retinopathy, such as hemorrhage, exudate, etc., we will say, okay, this patient should have another picture in, for instance, 1 year. Or if we see some kind of sign, early signs, we will send it right away to a local ophthalmologist, and maybe later on in the project, when we get an automatic algorithm, we will have it done. We will have that done automatically, not only the diagnosis, but also the treatment counseling.
And I just want to make clear that in the other projects, one of the pitfalls, as Matias said, was that although the patient was easily diagnosed, also using the automated algorithm, but then if we look at the numbers of patients that really got to the step of treatment, is very low. And I think this is what is different in our project, that we will link into this network also local ophthalmologists, not only local general practitioners, and then the patient will, it will be scheduled for him and he will know where to turn in order to get the proper treatment.
Agree. Yeah. That's your part, Dina.
Okay, so as we said before, it's a win-win situation, not only for patients that will have health coverage which will be accessible and easy to reach, but of course also for the government or for the health insurance and so on, that they will, on the long run, save costs by avoiding late complications.
Yeah, I would like to point out here that if you go and check and do a national screening, you will see that the first treatment in developing countries is not laser, it's vitrectomy. So the patient, if the patient have this patient has more information, we have to catch the patient when they are going for a driving license, when they are going for a ID. So those pictures will be taken in these different facilities, ID facility from the government, when they're going to take the driving license, etc., etc. It cannot be possible in 2019 in developing countries and some developed countries. The first treatment, if you do a kind of statistics, is vitrectomy due to a diabetic retinal detachment. Yeah, and the idea is to start in Argentina, and then we are going to spread this project around the world. Why we are going to start it? Because we have already started there, and we set the retinographers in the south, east, west, and north. And nowadays, general practitioners and nurses, they know how to click a button and get a widescreen picture. And we have been doing tele-IMD, that means telemedicine diagnosis, already here. But of course, we need the resources to spread it around the world. So the national coverage here in Argentina is very well done. So every single people and population here, every single one, when they need an ID or when they go for driving license, they need to at the same time get a checkup. With that means blood test, and we are going to add the picture as a fundus examination. And the general factor is that only 46% of the diabetic patient get DR screening. On the other hand, 100% of the patient gets an ID. So when they get an ID or again driver's license, we can take a picture there. That's you got the opportunity to diagnose early signs of diabetic retinopathy. And we did some statistical math, and the national spending on diabetes is more than $1 billion US, and this could be easily saved and reduced by this project if we can get it True.
And here, just to explain one more time, what is our advantage in the project we want to raise in comparison to other things. So, of course, we will need to build up the infrastructure, and we would use existing technology to start in Argentina, which we just said is on the rise with telemedicine, because they have huge areas of poor coverage, and they're making efforts to cover those areas with telemedicine already. And we're aware of the advantages and disadvantages of automated detection, so this will be human controlled. And again, we will have the link to the local ophthalmologist if we need it, in order to get the direct consultation and the treatment done.
Yeah, I think with this project, it's very important not only for the patient but also for the health system, national health system, public, private health insurance, but mostly for people. I mean, they are coming to the office with the diabetic retinal detachment, and they didn't even know that they are diabetic patients. So I think it's a unmet need, and with this we can fix it very easily. So Dina, do you want to add anything else to another this time?
We want to thank you for taking time going over it, and of course presenting it in our name and in your name. Yes, and if you have any further questions, we'll be happy to answer.
Yeah, again, we are grateful and delighted that you are close to us and we are close to you, and that you are our mentor and our friend, and we are very delighted and touched by this. So I think with this we are trying to help a little bit. Of course, no one is better than you to deliver any lecture, but this one in particular. So you will receive not only this video but also the presentation and the whole manuscript. Please do not hesitate to contact us anytime if you have any further question or whatever you want to say. Thank you so much.